Yeah, can you hear me now? Can you hear me
Yes,
now?
yes. Clear and loud.
Okay. Sorry, I
So
was in.
this is a operative scenario discussion today. We will
Yes.
discuss the laparoscopy repair of ventral hernia. So you can
Yeah.
start with the indications, contraindications. So Dr.
Sure.
Momita Das, who is second year junior resident at Bakura Shumili Medical College, will present. So Dr.
Great.
Beg, we can start. It's like a exam scenario.
Okay.
Take a heading of lap repair of ventral hernias. So you can start with your usual questions. It's your favorite field.
It is. It is. I'll be happy to hear. So is she presenting or am
Good
I?
morning.
No,
Good
I
morning,
asked her not
sir.
to present now. She had a presentation, but what I said, we'll first go through the exam scenario, and at the end, we can share her slides.
Okay. Okay.
So, exam scenario. Just she got a card, laparoscopic repair of ventral hernia. I'm not specifying, so we can. The field is wide. IPOM, IPOM plus,
Okay.
eTEP.
So I should ask questions from her and she's going to respond and then that's how it goes.
Yes,
Okay.
yes,
So Dr.
yes.
Madhumita, right? Dr. Madhumita.
Dr. Momita.
Dr. Momita, I'm sorry.
Momita,
Yeah. Oh,
Momita,
sir.
Momita.
Good
Okay.
morning, sir,
Yes.
and wish you
We
all
can start
very
with
happy New Year.
just.
Thank you.
Okay.
Yeah.
Thank you, Mamita. We can start with EHS classification or just your favorite question of how to decide about the different
Yeah. So Dr.
techniques.
Momita, I'll
Yes,
frame the
sir.
question. I'll frame the question for you. There is a 36-year-old female who has had a hysterectomy 5 years back, and
Mm,
she presents with a painful lump in the lower abdomen. On
mm,
examination, you see a reducible hernia about 4 centimeters above the pubis bone in the
mm,
midline.
mm,
And this is a reducible lump, has a cuff impulse.
mm,
Patient, otherwise, other systemic examination is normal. The rest of the abdomen is normal. There's only one phalansteal incision in the lower abdomen. Apart from that, there's no. So first of all, what is your diagnosis?
Sir, it is a case of midline. According to EHS classification, it is
Financial,
M4
financial
incisional
incision.
hernia.
Yeah.
Okay.
What? The aim what?
M4.
Okay. And if the defect width is 3 centimeters, what would be the W?
It is W1.
Great. Wonderful. So for the benefit of everyone, M1, M2, M3, M4, M5 are midline hernias. And if it is within 3 centimeters of xiphoid and pubis, they are M1 and M5. From the umbilicus, if it's 3 centimeters above and below, that's M3, and the rest of it is M2 and M4. So this one was 4 centimeters above pubis, so it is M4. Now we've diagnosed this as incisional hernia, and we've investigated and we have planned her for surgery. So tell me, what are the things that you will see on a CT scan for this patient before taking this patient for surgery?
Sir, I have to find out whether there is what is the gap defect, that is basically the width of the defect, and content of the hernia.
Okay. Okay. So apart from that, so you looked at the width, defect width, defect length, defect location, you confirmed.
Defect location.
Defect content, you said. I think on a CT scan, as surgeons, what we also want to see is the multiplicity of defect, which cannot be seen clinically. Multiplicity of
Okay.
defects. It could be one defect clinically, but you might get more defects. Anything
Multiplicity.
else you would like to see in this patient?
Can you
Sir,
assess
it
the
is a case
abdominal
of
layers? Can you assess the
incisional
abdominal
hernia.
layers?
Yes,
Abdominal
sir.
layers.
Yes. Yes. In we can find out the defect is in which layer.
No, defect will always be at the peritoneal level and come out through the sheath. That's fine.
Yeah. Yeah.
The quality of the external oblique, the internal oblique, the transverses, and at this level, you would like to see the rectus and the different layers. Why is this important? Why do you want to see the layers, all the abdominal muscles that you want to see? Why do you want to see them?
Because when we go for laparoscopic approach of IPOM or IPOM plus, we have to place the mace below the recta sheath, though it is known as onlay mesh repair. It is a type of, it is a kind of misnomer, but we usually put the mace through the through the peritoneal side beneath the recta sheath. That's why the all the muscle layer integrity is very important.
No, no, no. In IPOM, it's not retrorectals. Try to understand what the question was. Why do you want to assess the muscle layers? What does it indicate? Suppose in one patient you find the muscle layers are very much attenuated. What is the implication?
Okay.
Sorry, sir.
No, that's okay.
Yeah, yeah.
So basically, the idea is to know the layers because you may decide to do a surgery based on what is your field defect. Field defect means that if you have a hernia, then the
Hmm.
surrounding tissues may also be weak. For example, there could be divarication, which you can pick up on
Hmm.
a CT. Then you have to
Hmm.
address the divarication also. Number two,
Hmm.
it is possible that the peritoneum at that layer is so violated that you will not be able to do a retrorectus repair. Let's say you wanted to do a
Okay.
laparoscopic repair, but you
Hmm.
wanted to either put the mesh intraperitoneal or
Hmm.
preperitoneal, or let's say retrorectus.
Hmm.
The term is called sublay or underlay. Now, what
Only
is
underlay, yes.
I will keep it simple for you. There can be an intraperitoneal mesh, or it could be a sublay mesh. A sublay mesh is preperitoneal or retrorectus. Is that clear?
Hmm. Yes, sir.
So if you want to put your mesh in the sublay plane and the peritoneum is tattered, then you can't do it. So preoperatively, just assessing on a CT scan, you will know, okay, will I be able to do a retrorectus repair here or not? A sublay repair here or not? Now we'll build this. We'll build this a little further. So now this patient is scheduled for surgery, and I'm saying that this is 4 centimeters above the pubis. And I'm asking you, Dr. Momita, is IPOM possible in this patient?
Yes, sir.
Because
In
now
this
you
case,
said,
IPOM.
intraperitoneal onlay mesh hernioplasty. Onlay is
Hmm.
a misnomer because it is not on the external oblique, but it is the right term would be underlay. So
Underlay.
IPOM, IPUM. But let the misnomer stand. As long as you understand IPOM means intraperitoneal mesh, it is fine. So, Dr. Momita, can we do an IPOM in this patient with a hernia 4 centimeters above the pubis?
Yes, sir. We can do.
Okay,
No,
so I'm saying
you have to think carefully. If you put the IPOM mesh, you need to place the mesh and what structure is there close to this defect.
Sir, it is 4 centimeter above the pubis, so we
Yes,
can
4
do
centimeter.
above the
Yes.
pubis. So we can go for IPOM or IPOM plus here because if it is close to pubis, then there is a it is close to bony structure, then it is difficult. But here I can go for IPOM plus or IPOM.
so.
Okay.
How big a mesh would you put in this patient? First, let's start from there.
Sir,
Then I.
in case, yes, sir, in case we have to try for 5 centimeter overlap the defect. So if the defect is 4 centimeter, then the size of the mesh should be 5 plus 5 plus 4. That means 14 centimeters should be overlap. That means 15 by 15 or 20 by 15 size of mesh I will prefer.
So if this defect is 4 centimeters above pubis, then you are definitely not be able to put in a mesh overlap of more than 4 centimeters. And also, Remember what is there in that area? There is urinary bladder.
Bladder.
The urinary bladder is there. Can you fix the mesh on the urinary bladder? Can you pass a tacker through the
No.
urinary?
No. Yeah. Okay.
That was the
So,
question.
eTEP will
Understand
be.
that question.
yeah.
Yes.
So in these cases, let's say I am just shifting this. If the hernia was in the umbilicus, then you can do an IPOM, right? Because you will get an
Yes.
overlap of 5 centimeters or 7 centimeters all around the defect for the mesh, for the coated mesh. Huh? But
Mm.
when the defect is close to a bone, so this is pubis. If I said the
Mm.
same thing, that there is a epigastric hernia 3 centimeters from the xiphoid, can you do an IPOM?
No, sir, because there is a
No.
rib cage and the xiphoid process. That's why
Correct.
we will
And
prefer
the
to
heart.
avoid
Yes. And the
heart
heart. And
structure.
correct. So if I said again, I am going to change this a little bit. There's a subcostal hernia after an open cholecystectomy incision. Can you do an IPOM?
Yes, sir, it is L1, so we can go for.
Again, same thing. As long as it is near a bony point and there is a vital structure underlying, you cannot tack. So if you said IPOM, you will have to say in a subcostal hernia or a subxiphoid, if I did an IPOM, I will not fix the mesh above the costal margin. If you said this, it is still acceptable, but you cannot say that I will do an IPOM. So what point we are saying is you will do an IPOM in midline hernia, in M2, M3, M4, some part of M4 you can do, but M1, M5, L1, L3, L4, you cannot do IPOMs. Okay?
Okay, sir.
Yeah. Is this getting clearer or is it getting
Yes.
confusing? Is
No,
getting
sir,
clear?
it's clear. Mm.
Okay. Now, coming back to the same patient. Now we have this patient with a hernia 4 centimeters above the defect. Now, I told you that we can do an IPOM. It was if it was an umbilical hernia, right? If there was a incisional hernia at the umbilical level, M3 level, we can do an IPOM. So first, let's take the umbilical level. There is a hernia at the navel area, and you have decided to do an IPOM. First thing, what are what is the position of the patient and what is your port positions?
Sir, if it is umbilical hernia, then it is M3 and we can go for IPOM or IPOM plus. In that case, the patient position should be in the supine position and
Yes.
hand keeps in side where the monitor placed on the right hand side of the patient, surgeon, scrub nurse and camera person on the left hand side, anesthetist on the head hand side. Now the placement of the trocar usually done through the laparoscopic triangular fashion. Usually the first we have to take three trocar, one 12 millimeter trocar for introduce the laparoscopic camera, 30-degree telescope camera and two 5 millimeter trocar. But some surgeon can prefer one more 5 millimeter trocar. That means total 4 trocar or it can be 3 trocar. And first trocar usually insert it at the palmer's point, which is 2 to 3 centimeter below the subcostal margin. And on the lateral side of it, the other 2 trocar is placed.
Okay. Now you made the point clear. What is your first entry into the abdomen in this patient to make a pneumoperitoneum?
Closed or open?
Sir, usually it is preferred the closed method to create the pneumoperitoneum by applying the Veris needle, or we can go for pneumoperitoneum creation by the open technique by using the Hassan's droplet. But in case of obese male patient, though it is a case of female patient, but if it is an obese female patient, then we can go for OptiView technique where we will use the optical trocar entry should be preferred because of the thick anterior abdominal wall.
So let's redefine your answer. The entry to the abdomen in incisional hernia is crucial. It is a violated abdomen. correct? It is a violated
Yes, sir.
abdomen. So whenever
Violated
there
abdomen.
is a surgery in the abdomen, you would like to ensure that there is no injury while making your first entry into the abdomen. Now, three methods. One is varus entry in the palmer's point. Palmer's point,
Mm.
right, which you
Palmar
mentioned. So
spine.
varus entry in the palmer's point. Number two technique is the open technique. Again, difficult in incisional hernia because if the hernia is usually in the midline, even the open technique is difficult, but we all try to do it at the palmer's point. And number three is the optical view, optical entry. Now, all
Mm.
these three will be irrespective of gender or obesity. You mentioned male obese, but why? If it was a female obese, wouldn't I use an optical entry? I
Yes,
might.
obviously.
So
Mm.
all three techniques are possible. What do you prefer?
Mm.
Let's say you did a very entry at the palmer's point and you put in a 5 mm telescope at that area and you looked into the abdomen and you find all the adhesions are infra umbilical and nothing is superior. So you put in two more ports on the
Mm.
axillary line as you mentioned, one 12 mm or a 10 mm for the camera and one 5 mm for the instrument working port in a triangular
Mm.
manner. Now, what is the first step after this?
So actually the IPOM or IPOM plus repair is based on Pascal's principle. The principle said that the force which is required to create the defect of the hernia is equivalent to force we apply to place the mesh. So therefore, after creation the pneumoperitoneum, I will introduce the laparoscopic camera for diagnostic laparoscopy to look for whether there is a presence of ascites or there is a presence of abdominal TB. If it is present, then we abort the procedure. And if it is not there, then we have to introduce the laparoscopic camera and then the other two trocar placement. Then we go for first step, that is the adhesiolysis. But it should be done very, very carefully because the main disadvantage of this minimal access surgery by laparoscopic procedure is the bowel injury, which is 4%. And that's why the adhesiolysis step, which is the most common intraoperative injury, is the gut injury or the trocar injury or injury to the vessels. So we have to carefully do the adhesiolysis. And after doing the, because and the main importance or aim for the adhesiolysis is to clear the hernial gap margin. Therefore, we can assess the defect. That's why we will go for adhesiolysis. And adhesiolysis should be done with the help of diathermy. But in case where the gut is present, we will usually try to use the scissors. And after adhesiolysis performed, the reduction of the hernia content should be started. And during the reduction of the hernia content, external counteraction force is applied by the assistant and that is actually facilitate the reduction of the hernia sac content and lower the abdominal ceiling to provide the better working place.
Good. So I will
Good.
make two changes. One, don't say that you are entered and you are looking for ascites and TB. You just say a
Okay.
diagnostic laparoscopy is done to exclude contraindications. If the in the so contraindication could be anything, but ascites and TB will not be the commonest thing. You've already done a CT and incisional hernia. You entered the abdomen. 99.99% you will be completing the procedure. So just say diagnostic laparoscopy. A more common
Mm.
finding would be
Yeah.
incidental cirrhosis, in fact, not
Yes.
anything. So that's
Mm.
one rectification. And yeah, you said adhesiolysis for looking at the hernia defect. No, not only that. You're doing adhesiolysis not only for looking at the hernia defect and reducing the content of the hernia, but also creating a space for the mesh to come in. It's called the landing zone. Landing
Okay.
zone of mesh has to be created by adhesiolysis. So the
Mm.
landing zone is not there. Where will you apply the mesh? So you must do adhesiolysis enough to place a mesh on the anterior abdominal wall. Okay.
Mm.
Now,
Mm.
once you have done all of this, you have decided that now you can see the defect. It's a 4 cm defect at the navel, and there are no further defects. So now, what are you going to do? What's your next step?
Suppose one situation
So,
that Mamita, you find that
mm.
falciparum ligament is very prominent.
Close to umbilicus,
And
yes.
and then is it necessary to do something with the falciform ligament as you place the mesh above? Is very prominent, hanging just beyond the umbilicus. Will it hinder the placement of the mesh properly?
In case of M3 hernia repair, it is obviously, sir, hindering, because if it is very prominent.
And
Yeah.
then what you do? In that case, to place the mesh properly, you might need to mobilize,
Mobilize the
divide the
falciform
falciform
ligament.
ligament from the level of umbilicus to the point. Yes, to the point you need to place the mesh. Fine. Chalo, ठीक है. So you assess
Yes,
the
sir.
gap.
So both things
Then,
can happen.
sir,
Urinary bladder and falciform both may come close enough. Bladder will definitely will be very, very low, but falciform may come close enough. So you must say that I am going to dissect the falciform ligament away to create a landing zone for the mesh. Again, same. Try to use this word for landing zone for the mesh. Okay, done. So you have done this also. Then what?
then I want to measure the size of the defect, and to measure the size of the defect, first I want to reduce the intra-abdominal pressure from 12 to 15 millimeter of mercury up to 6 millimeter of mercury. Because of this reduction, it helps to two things. One is oppose the defect margin, and helps to assess the defect size. I will get the accurate size of the defect. And once the margin of the hernia well delineated and cleared, then defect of the hernia can be measured by external palpation or with an internal abdominal ruler or laparoscopic instrument, or by the suture technique. And after measuring the size of the defect, I will apply the mesh.
And
Right. So
and if
now,
you are doing IPOM plus,
In case of IPOM plus, I have to close the defect with the non-absorbable sutures by intracorporeal as well as the transfascial technique.
not and
both are not
or.
required in the same patient.
Both, yes, sir. Both, sorry, both.
Both strategies are possible, but one will be used, either transfacial or intracorporeal. Correct?
Yes, sir.
Yeah. So now you have closed the defect, and after the closure of the defect, you are ready to put in the mesh. What is this mesh called, which can be put inside the peritoneal cavity, which is gut friendly? What is it called?
Sir, there are three kind of mesh. One is coated mesh, uncoated mesh, and the composite mesh. But in case of IPOM plus repair, we usually prefer the coated mesh, which has actually two layers. One is parietal layer, another is visceral layer. The visceral layer is actually close to peritoneal side or the gut side, which is coated with absorbable anti-adhesive material, which is usually made by the cellulose carbohydrate antigen, and that may be sodium hyaluronate, polyethylene glycerol, polyglycerin, or omega-3 fatty acid, like this. And the parietal layer, which is basically close to close outside the
No.
peritoneal layer, that is non-coated, and we prefer the coated polyester, polypropylene, or PTFE mesh.
Okay, so a few corrections. One, what is the difference between coated mesh and composite mesh?
Sir, in case of composite mesh, there is one layer that is PTFE, and another is coated polyester or polypropylene, and one is coated mesh. This is the composite mesh, and one it is coated mesh. Then the polyethylene or polyester mesh, that is one layer that is known as the visceral layer, that is basically coated with uh, anti-adhesive absorbable material. That is the coated mesh.
So may I suggest that you just say coated mesh, uncoated mesh. Don't bring in composites because that's a brand name. Say
Okay.
coated mesh, uncoated mesh. Uncoated mesh is polypropylene and polyester.
Polyester.
We use groin hernia and usually polypropylene.
Mm.
And as far as ventral hernias are concerned, when you're putting in the mesh intraperitoneally, we are using coated
Mm.
mesh. What is the
Mm.
coating? Now you can say the coating is on the side of the gut, the other side is uncoated, and the coating can be absorbable or non-absorbable materials. For example, we use hyaluronic acid, collagen, carbohydrate, and a
Mm.
non-absorbable coatings are like titanium. So these,
Titanium.
yeah, so there are absorbable coatings and non-absorbable coatings, but these are anti-adhesions barriers which are
Mm.
employed on the visceral surface of the mesh. This can be absorbable or non-absorbable. All right,
Mm.
keep it
Yes,
simple.
sir.
They will ask you
Mm.
about the brand name and what is the weight and all that, but at least you say coated, uncoated. Coated could be these coatings. Why? Anti-adhesion, so the gut doesn't get adherent to the synthetic mesh like polypropylene, which is
Mm.
on the other. Okay. Now, how
Mm.
will you fix the mesh?
Sir, mesh fixation can be done by three ways. One is suture, another is tacker, another is glue fixation. But better we have to go for the dual technique, that is suture as and the tacker. Because if we use only suture, it causes pain. If we use only tacker, first of all, it is more costly and there is increased chance of mesh migration. So we have to go for dual technique for the mesh fixation.
Okay. So how will you centralize the mesh here? The mesh should be central. The overlap has to be symmetrical. How will you centralize the mesh?
Uh, for centralization of the mesh, first uh, we put the
Does the
suture
mesh
at
come
the
with
four.
pre-tight sutures? Momita, does this mesh come with pre-tight sutures? Most of these
Yes, sir.
coated
At
mesh
the
comes with,
four pre-types. Yes, sir. At the four corners.
yeah.
Hmm.
Different
Yeah.
company has a different placement, but
Yes.
most of these come with pre-tight sutures, either two sutures or four sutures. And Dr.
Yes,
Beg has
sir.
asked you, how do you centralize? That means you have to place the center of the mesh at the level of umbilicus, and then the
Hmm.
mesh will be all around. How do you do that?
Hmm. Sir, first we have to, if in suture fixation is decided, then suture should be placed at the four cardinal point of the mesh, and then the mesh is wrapped around a laparoscopic grasper and inserted through the 12 millimeter trocar. Once it is inserted, the mesh is unfurled and oriented correctly. The pre-placed sutures are pulled transabdominally using a sutured passer through the previously marked
Before
location.
that, before
Before,
that, before that, do you need to mark the corners where from you will bring the sutures? Because that is important. You
yes,
have
sir.
four suture in the corners.
Yes,
Then at what point you will make the abdominal incision?
uh, sir. Actually, it is 6 to 7 centimeter away from the working area.
So
No. So when
umbilicus is the center.
uh, you can mark the mesh on the abdomen. Let's say
Hmm.
you're going to put in a 15 by 15 centimeter mesh in the
Mm.
abdomen. Depending on the obesity of the patient, you will mark, let's say, a 20 centimeter by 20 centimeter area on the surface of the skin. And at
Hmm.
each point of the angles, the corners, you
Hmm.
make a stab incision and pull out the thread that you have attached to the corners of the mesh, or they are already coming prefixed, pre-tied from the manufacturer. So you either have to mark the mesh on the skin and make a
Hmm.
stab incision and take it out, accounting for the obesity, subcutaneous obesity for the mesh, and then take it out. I have a picture I will probably show you in the end to make an impression on that. But that is how centralization can be done. Or you can take a central suture, which
Hmm.
comes to the center of the defect. And if you pull it, then the mesh will remain symmetrically covering the defect from all sides.
All
Okay?
sides. Okay, sir.
Okay. So now you have put in the mesh, you have tagged, you have fixed the mesh also. And you, what is the last thing that you might want to do to prevent adhesions?
Sir, I have to look for any, before remove the laparoscopic camera, I have to look for whether any intraoperative injury present or not.
Okay, good, good. That's good. And the other thing is you put in some omentum between the bowel,
Omentum, yes. Yeah.
okay, to prevent further adhesions. Okay, fine. Vakanda, can we move on to other things?
Yeah. What is the end point that you cannot do a IPOM plus? IPOM plus is one where you oppose the gap. So what is the, or rather you can discuss about what do you mean by a complex ventral hernia? These are simple ventral hernia we're discussing. Well, there are
Yeah,
some definition for complex ventral hernia. What are the criteria to say these are complex ventral hernia? Because this needs a different approach.
yeah. So, Momita, what's the complex ventral hernia? Just to make you
Sir,
feel better.
actually, in case of ventral hernia, when there is a presence of symptom like pain, strangulation, or incarceration, or there is a presence of
No,
umbilical
no.
necrosis,
These are
then we go
complicated.
for
No. Don't confuse. Complicated hernia and complex hernia are different.
Mm.
These are complications, obstruction, strangulation. Complex hernia is defined by number one by the gap. We are discussing so long a gap of 4 centimeter. When
Hmm.
the hernial defect is more than 10 centimeter,
More than 10
it's a
centimeter.
hernia
Hmm.
where the gap cannot be opposed. Number one. Number two, Dr. Beg has told you that instead of one defect, there will be multiple defects. So if you have multiple defects, you have to take all the defects together to say that this is a hernial gap.
Okay.
Okay, so this become a
Hmm.
larger gap. Next is
Okay.
this patient already had a hernia repaired earlier. It's a recurrent ventral hernia that is complex. You have a patient who had some earlier surgery and now patient is coming to you with a ventral hernia plus there is a intracutaneous fistula or a infected
Hmm.
sinus.
Hmm.
Okay, so
Hmm.
these are the few important situations and you have a very large hernia and we define that patient has loss of domain.
Loss of domain, yes.
Okay,
Hmm. Hmm.
so these are the criteria to say this patient has got a complex hernia because this complex hernia you cannot say to or decide to do IPOM or IPOM plus.
Hmm.
True. So,
Okay.
very important, you need to differentiate that we were dealing with a simple ventral hernia, and now we talked about complex ventral hernia. So, when it is complex, largely there would be open surgery, a lot of optimization is needed. Some can be taken for minimal access, but most will go for open surgery. So, based on defect, width, defect multiplicity, defect location, the content size, previous hernia, previous mesh, and previous mesh complications. All this will make hernia complex. So that is hernia factors making hernia complex. And there's something called patient factors making hernia complex. For
Yeah.
example, if it is a severe obesity, then this patient, although has a small hernia, it's still complex because in a BMI 50, even with this navel hernia, it becomes complex. The recurrence rate is
Hmm.
very high. If the patient has an underlying cirrhosis and a and there's an umbilical hernia, even though it is a small umbilical hernia, even then it becomes complex. So patient factors can also make it complex. Hernia factors can also make it complex. So that is a definition, a good definition of complex hernia. Now we can move on. After the IPOM, you realize that there is a lot of limitation to IPOM. You can't do complex hernias with IPOM, IPOM plus. There are also certain hernias where it is desirable to use sublay repairs. Okay, sublay
Hmm.
repairs. What do you mean by sublay? is the first thing.
When we put the mesh beneath the rectus muscle, this is called sublay.
Either it is below the rectus muscle and in front of the posterior rectus sheath, or it could be pre-peritoneal, right?
Pre-peritoneal.
So both are sublay mesh repairs. What do we discuss in IPOM is an intraperitoneal repair. Now, as I said, this patient is 4 centimeters above the pubic bone, right? In this patient, you can't do an IPOM because there is urinary bladder. You can't fix the mesh through the urinary bladder. Neither will you have good overlap. So you can do something which is sublay repair. MAS sublay repair. What is this? What are the various minimal access sublay repairs? Can you name few of them? Then we'll take it forward. Can you name a few of them?
Sir,
some other ventral hernia repair laparoscopically. We have gone to IPOM plus. Next is
sir,
eTEP.
sir, TARM, that is the total
Yeah.
abdominal retromuscular, that is the sublay repair.
Total?
Transabdominal, not total.
Sorry, transabdominal retromuscular repair.
Okay, TARM. What else?
Transabdominal
Yeah.
preperitoneal.
Yes, TAPP.
Yes.
Transabdominal
extra
preperitoneal,
peritoneal,
transabdominal
extraperitoneal,
retromuscular, and one more, if you can say, it's good.
rib stupa.
eTEP.
eTEP.
Extended view,
Yes.
totally extraperitoneal repair.
Extraperitoneal
It's a
repair.
misnomer. It's an extended view, totally extraperitoneal repair. It's a misnomer, but it is basically an endoscopic reef stopper repair. Okay, endoscopic reef stopper repair, that is called eTEP. So these three techniques are possible. There is another technique called tape transabdominal partly extraperitoneal, which is the commonest surgery done for these cases. And you still use a coated mesh because part of the mesh is extraperitoneal, part of the mesh is intraperitoneal. But let's now, because eTEP is also part of this talk or this meeting today, let us go a little bit on the difference between TARM, TAPP, and eTEP. So TARM and TAPP is transabdominal, you're going, and then you're going in the sublay space. So you're making a peritoneal incision or an incision on the posterior rectus sheath to enter these spaces, either retromuscular space in a TARM, in a preperitoneal space in TAPP. Right? How is
Yes,
the eTEP different from these two procedures? How is the eTEP different? That's the first concept that has to be cleared.
Where is the access?
Sir, sorry, sir.
Where is the access in eTEP?
Sir, in eTEP, actually the eTEP first introduced for inguinal hernia repair, but Dr. Deliansky sir introduced it for the ventral hernia repair also. Here it involves the opening of rectorectus space along with the preperitoneal space of Regius and Bogros at the groin.
Okay. So you start saying something like this, that the eTEP technique was devised initially for groin hernia to have a more extended view by taking the trocar, which was usually subumbilical, to supraumbilical level, correct?
Yes. Yes, sir.
Now it was realized by Dr. Belyansky that it is possible to create the entire reef stopa space, which means the retrorectus space from one linea seminaris to another linea seminaris, from xiphoid process to space of Regius. This entire space can be created, and this is called the eTEP space, or the axis is called eTEP axis. Now, let's go into the nitty-gritty, because that will make you understand what I'm saying. What is the first, where is the first port and in which level? So where is the first
Sir,
port? Which
You
layer?
have a parumbilical hernia and you are decided to do
so
eTEP repair.
If it is
Paraumbilical hernia.
infraumbilical paraumbilical hernia, then the first port at the left
Subcostal.
subcostal region, left
Yeah.
subcostal.
Yes. So left subcostal, open technique. You cut the skin, the subcutaneous fat, you cut the anterior rectus sheath, you split the rectus muscle, and you see the posterior rectus sheath. You take a balloon, you dissect a retrorectus space, and then put in a 12 millimeter trocar. Correct?
Yes, sir.
And this is via a 15 millimeter incision.
15 millimeter incision.
Yeah. So now you have put in a 12 millimeter trocar through this. Now the camera has gone in. Now where are the, you create 4 more space in the retrorectus area and you create 2 more working ports. Where are they?
Sir, if it is left subcostal, then and in case of infraumbilical hernia, then other 2 ports should be the lateral of the first port, that is right subcostal region, and another at the just above the left side of the umbilicus.
No, no.
What is
So
the
you
relation
see,
with the linea similionaris? Relation with
Yes,
linea
sir.
similionaris?
you are in the left retrorectus space now. You haven't seen the right retrorectus space. You just made one left subcostal port and you have a left retrorectus space created. Now, where are the other 2 working ports going to come?
One
When you
is
will
right
create
upper
them,
port.
no right. There is no right space at the moment. You are in the left
Right upper port
retrorectus.
afterwards, not now. Not now.
You are going to
Right
make one
upper
more
port
port.
is afterwards.
Yeah. You're going to make one more port, 5 to 7 centimeters below the first subcostal port, medial to the left linea semilaris. Correct? Medial to the left.
Okay. Medial
Linea
to the left linea subcondyle. Yes, sir.
That's the first 5 mm trocar. And then another one again 5 to 7 centimeters below the first working port, which is again medial to the left semilaris. All right.
Yes.
So now
Yes,
you've
sir.
All
got
the
3
ports are in
ports
the retrorectus space.
in the left side. Now what are you going to do? Take the camera to the
Then we have to create for retrorectus space
yes, create the
by
retrorectus space right till
by
the
2
space of
method.
ZCS. Yes,
Yes, sir.
please
Up to
show.
the pubic bone.
Yeah,
The
yeah.
dissection should proceed caudally until the pubic bone is completely visualized, and it can be done by the 2 method. One is balloon method, another is the finger dissection.
Now you don't
Hmm.
need balloon or finger because you already have a working port, so you can use.
Working port is there.
So what I'm going to do is, Maganda, just for their
Yes.
benefit, I will
Yeah, yeah.
share the, because this is something that they should see to understand. Here you go. Can you see the, can you see
Yes,
this?
yes.
Okay.
Yes, yes.
So this is your port configuration. Just look at figure 1A.
Hmm.
1, 2, 3, 4. I told you make your first port, which is number 2. Only look at figure 1A. So number 2 is your left subcostal port. Number 3 and 4 are your 2 more ports that you made medial to the left linea semilaris. I have marked the linea semilaris for you. So 2 more ports. Now you take, what we do is the first thing is that number 2 is the 15 millimeter port, the first one, and the 3 and 4 are the working port generally, but it will interchange. This is the way the camera is going, and those are your working ports, right? I'm going to show you. This is the incision you're making on the left subcostal side. Rectus muscle split. We are entering with a balloon. We inflate the balloon, create the left retrorectus space. You can see the posterior rectus sheath below, the rectus above. Now, when the port has been made, you can see neurovascular bundle on the left side, and we are going towards the space of Retzius. That is the arcuate line, because all of a sudden you find that the PRS has disappeared. And then you go to see the space of Retzius. You can see the epigastric vessel, the pubic bone, the space of Retzius, right? Now what are
Yes,
we
sir.
doing? We are taking the camera to number 4. We're taking the camera to number 4. It's a 5 millimeter camera. And we'll take the hook at number 3. With number 2, we will depress the PRS, and with number 3, we will cross over from the left retrorectus space to right retrorectus space, keeping ourselves above the falciform ligament. See this. We are cutting the left posterior rectus sheath. You can see the rectus muscle above. And we are cutting the left posterior rectus sheath. And what we see, not the abdominal cavity, not the peritoneal cavity. We are seeing the falciform ligament, right? We know from our anatomical knowledge that we will see the falciform ligament. Now what we will do is we'll stay between the linea alba and the falciform ligament, and we are bringing the falciform ligament down. And once that is done, we can see the opposite side posterior rectus sheath, right? Now we will see the opposite side posterior rectus sheath, and I'm going to make an incision on it. In this patient, we have also created, now you can see the posterior rectus sheath very well. We have opened that space, and you can see the rectus muscle. Now there's a trocar already lying there because it is a teaching video. I want to show you that you can keep another trocar there already so that it is easy to identify the right rectus space. Okay? So far, so
Yes,
good.
sir.
This is a tricky part. So this is the tricky part. Understand that you were in the left space. You created the
So
left.
this is crossover.
Now, this is the crossover. The camera is in the bottom. The middle port is being used with a hook. The top port is using to depress the PRS of the left side. And now we have crossed over and gone on to the opposite side. Now we have made. Now your camera will go to the port that you made on the right side. You see the right subcostal space I had put in a trocar. Now this is the port that you make, and you keep the camera at the top. And with number 2 and 3, you start working. Now there are many ways. This is the classical method I'm telling you. Remember this. The camera is at the top. 2 and 3 are your working ports. Or you can keep the camera at number 2 and you can make 1 and 3 as your working port. That will give you more triangulation. Okay? But there will be more
Yes, sir.
clashing. See this. We are going downwards, we're cutting the PRS, and we're looking at the peritoneal cavity for any additions. You can see the content is omentum. We are bringing it all down from the cavity. And because it's omentum, you can use energy source. If it was bowel, we will not use energy source, right? So we are trying
Yes.
to bring all of this down. That is the, dermal level. So we are going to keep it back to give it back to the skin. And we're bringing all the omentum down, and we're going to reduce it back into the abdomen. So now that the hernia has been reduced completely, this goes into the abdomen. And you can see the defect, right? You can see the defect. Now we're cutting the PRS on 2 sides. We are cutting the PRS on 2 sides and the peritoneum in the middle. Just behind the linea alba, there is a peritoneum and a fat layer. So what we are doing is we are cutting that, and we are cutting the PRS on 2 sides. So what will happen is you will reach what space by doing this? So the linea alba is at the top, the bladder is at the bottom, and the PRS on the 2 sides being cut. So where have we reached now? We started from the xiphoid, and where have we reached in the bottom? The space of Retzius.
Yes,
So
yes.
now you have a space from one linea seminaris to another linea seminaris. You have one space from xiphoid to pubis. This is one common space. It is called eTEP space, extended view TP space, right? Huge space now. Now you have got one defect at the roof, which is the hernia defect, and one defect at the bottom, which is what you cut in the hernia sac. When you cut the hernia sac, you will have a hole at the posterior layer, correct? If you
Yes, sir.
cut the hernia sac, you will have a hole at the posterior layer. So you have to stitch the posterior, you have to stitch the anterior before applying a mesh. So let's go and see. Now, this is, I'm just going to explain to you. Let's say the defect is very large and you cannot close the defect without tension. So you have to do something called a TAR. What is a TAR? Full form of TAR?
Transverse abdominis release.
Transversus abdominis. So that is a muscle that you have to cut so that there is less tension in closing the posterior and the anterior layer, correct? So how
Yes,
do you
sir.
do that? You see, this is the camera and the 2 working ports. So this is how you would do a TAR on the right side. And the mirror image of this on the left side, you will be able to do a left TAR. I'm showing you left TAR. See this. There's a neurovascular bundle. Medial to the neurovascular bundle, you cut the posterior lamella of internal oblique, and then you will see the muscle, which is the TA muscle, transverse abdominis muscle. Now you cut the transverse abdominis muscle with the hook, and once you cut, you are left with peritoneum and the fat posteriorly, and anteriorly the TA muscle. So you stay between the fascia transversalis and the TA muscle. So TA muscle is going at the top. You can see the TA muscle. And what is going at the bottom is the peritoneum, the fat, and the fascia transversalis. Sometimes it is not easy to get the fascia transversalis, but you try. So now you can see at the bottom is the peritoneum, the fat, the fascia transversalis, and the top is the transverse abdominis. How do you know that's transverse abdominis? It is transversely placed. That is why it's transverse. So you've done a TAR. Now what? Now we will stitch the defect. You see that is a defect? So we are stitching. Now with the classical technique where the camera is on the right and you are on the left, there will be no clashing. But if the camera is in the middle, then there will be clashing. So that is why all eTEP surgeons, whenever they're stitching the roof, they would like to keep the working ports towards themselves. So you see, this is the needle holder, the Maryland coming, and we are stitching the defect. So this was a big defect. That is why a tar would be helpful here. It will make it without tension. So just to show you, this is how the defect closure is being done. I'm just going to fast forward this and just show you in the end that once you have closed the entire thing, this is the barbed suture. The barbed suture has the advantage that nobody has to follow. When you release it, it won't spring back. Remember, in open surgery, somebody has to hold the thread, right? In this, you don't have to. It's a barbed suture. Now that is done. So the defect is closed. Now, the posterior, I told you there is two holes.
Posterior.
One is the anterior, one is the posterior.
Is not closed with delayed absorbable sutures.
Right? So that is the posterior. So the posterior layer, we are closing with the PRS. You can see we are closing transversely. So we are closing transversely because if you try to close vertically, there will be tension and there can be post-operative PRS disruption. But if you close transversely, the forces will not distract and it will not lead to any PRS disruption. So we are now closing this posterior layer.
Difficulty in.
Okay. Now, so once this is closed, just for now, you may have, if you have done TAR, you have a huge space. If you haven't done TAR, you have a less space. But what is the approximate size of the polypropylene mesh? For an endoscopic reef stopa, you would be able to apply 25
20 to 25.
Yes, 25 to 28 centimeters long and 14 to 17 or 18 centimeters wide mesh. But if you have done TAR on two sides, you would be able to apply about 30 by 30 centimeter mesh. So once this is done, you will see the mesh coming. This is a patient where TAR has been done. So now you will see how big the space is. We are measuring it to know how big the mesh has to be employed. That's the polypropylene mesh from one axillary line to another axillary line. So this is a 28 by 28 centimeters polypropylene mesh being put, and we are putting one tack at the Cooper's ligament, and then we are putting in some glue. You may or may not put this. This is optional, but that is how you place the mesh, and then you deflate. So what is important is minimal fixation. And because there is minimal fixation in eTEP, there is less pain. There is less pain. Whereas in IPOM, because there are so many tacks and transversal sutures, you will have more pain, right?
Yes.
So that is what I wanted to share, because eTEP is more difficult to understand unless you have a visual understanding. It is difficult to say it in the exam. So now I think I'll leave it to Makun.
Yes, yes. So actually, eTEP may not be asked in exam routinely, but if you have a examiner who is doing regularly, he may go into this. So basic principle is you have to access the retrorectal space. You have to make a passover to the opposite side, divide the PRS on either side of the. Don't damage the linea alba. You have to retain the linea alba in the midline, and you have to divide just lateral to the linea alba on either side, and then go on down up to this. But sometimes the criticism for this surgeries, people are saying that for a small defect, you are getting very large space and there is some chance of seroma or whatever. But still, this is a situation which is a bailout procedure for large complex hernias, which you can adopt. Okay, basically, what
Yes, sir.
Dr. Beg has seen, that is what you should describe. Access to the retrorectus space in the subcostal area, and then making further pores medial to the linea similaris, pass over, go up to the retropubic space and on either side on Bobrow space, and then create the space. If required, you do a tar. If not, if the gap can be closed easily, tar is not required. You just place the mesh, and fixation is optional. Okay,
Yeah.
Mamita, you have read
Yes,
well.
sir.
You have answered well.
Thank you.
Yes,
Thank you,
you
sir.
have, Mamita. You have.
Thank you. Thank you so much, sir.
Thank you. Thank you.
Okay. I think. Thank you very much, Mamita. We're very impressive. And all of you who joined, Makunda, special thanks to you. And
Thank
we'll
you.
talk.
Thank you, Dr. Beg. Yeah.
Thank you. Bye.
Thank you, sir.